Good evening, everyone, and a very warm welcome to all the participants joining us today for the webinar on neuroplasticity and its clinical applications. On behalf of the entire team at Neurophysiotherapy India, I extend my heartfelt gratitude to each one of you for being with us today. It is my distinct privilege and honor to introduce today's distinguished speaker. Our guest today, Dr. Karthik R Rao, is presently working as a Director, Clinical Operations at JOGO Health Private Limited. Dr. Rao has dedicated years of exemplary service as a physiotherapist towards patient care, education, and research. He has made significant contributions to the field of neurorehabilitation. With expertise spanning more than 2 decades, Dr. Rao has authored, has published, has researched several lectures and seminar topics at national and international forums. Today's session, titled Clinical Applications of Neuroplasticity, promises to provide valuable insights and practical applications on the topic of neuroplasticity in neurorehabilitation. I welcome you, Dr. Rao.
Thank you, Dr. Harpreet. Thank you for the warm introduction. So let me start my discussion. And at the outset, I would like to thank the organization, the Neurophysiotherapy Group, as well as Dr. Harpreet for inviting me, and welcome all participants for this webinar. And I'm aware that some of you might be watching this video on YouTube, so welcome you all as well. So we'll have a mix of both the groups, and what we'll actually try to understand is we are quite well aware of neuroplasticity, and today we are going to discuss about the various aspects of neuroplasticity and how it can be clinically useful for a practicing therapist. So with that let me delve into the topic. So let's start with a few patient videos to understand how we are seeing what we are seeing, right? So this is a patient who had multiple sclerosis, and as she was trying to reach the bottle, you can see that she is struggling to reach the bottle, and even the elbow supported in that case. And now after a month, she is able to drink independently, and you can see the elbow is not supported, so she is completely active. So this is a very positive change for this particular patient, and definitely brings it a lot of independence. Similarly, we were able to help a patient who had facial schwannoma in 2014, and she had post-surgery, she developed this unilateral paralysis of the face, and for 10 years she was suffering with that. In fact, when I spoke to her, she told me that for 9 months she took electrical stimulation back then, and then she gave up. So we saw her last year, and we were able to elicit some positive responses from these muscles. And then over a period of 5 months, we were able to help her to get some of her movements back as well. You can clearly see the progress that she had made. Similarly, this is a patient with spastic dystonia. So let me play the video for you. So here you can see that she is not using her index finger when she's picking up the object. When she's trying to place it, she does more with wrist flexion to get that extension in the fingers. Something like more like a phenotypic action using the passive insufficiency. And post-therapy, she's able to do this. With relative extension of wrist and active finger extension. Now, if I play this video live, I'm going to play the left one first and the right one later. You can see the fluidity of movement, like how easy it is for her to let go of that mobile phone. by the time she is still releasing, the right hand is back in the post session. So this clearly shows us that there are some changes that are happening and there's some progress that has been made by the patient. That leads us to a lot of questions like, are exercises driving these changes? Okay. And are these changes happening at the muscle level or at the level of the brain or both? What is happening inside the brain when we are actually teaching them or asking them, training them with exercises? Why does a patient regress when the exercises are stopped or the physiotherapy services are withdrawn? And how can I make the exercises more effective? Am I in the right direction? And is the patient active during the treatment session? So all of these are questions that are constantly bothering or comes to the mind of any physiotherapist. And so today, the topic we're going to discuss is about neuroplasticity, which is definitely a boon to humans. And we are going to look at how we understand about neuroplasticity and what is the recent advances and how we can use this in our day-to-day practice. The term was coined by Dr. Jerzy Konowski from Poland in the year 1948. And primarily, the term means that it is like a plastic, which means it is moldable. So we have different forms of plastic, right from a water bottle to a pen to a laptop to a table or a chair. So the plastic can take different forms primarily because it is moldable. So similar to that, the nervous system is also moldable, and that is why the term neuroplasticity shows that we can change the nervous system through experiences. So you can see a very ugly looking malformed person on the screen. So who is this? If you can guess, you can put those answers in the chat box. And those who are watching on YouTube, you can just pause this video for a moment and try to answer this question. Who is this malformed person? Is it an alien coming from some other planet, or what is this all about? Yeah, thank you for the responses. And you can see that this is something that we have studied in our college, especially in physiology. If you can remember this diagram, how the different parts of the body is represented in the brain. So this is our sensory homunculus. Okay, so this is the representation of our body in the brain. And as you can see, if you put all these pieces together, you will see such an malformed or a disproportionate limbs or disproportionate parts of the body. So what does this indicate? This actually indicates that the brain recognizes the body part not based on the size of the body part, but on the usage of it. So this is sensory, which means which part of the body is going to give me more information. I'm going to have a bigger representation of those parts in the brain. Similarly, we also have a motor homunculus, so which would be slightly different. But on a, let's say 90% of overlap would be there between sensory and motor. So the motor homunculus is which part of the body I'm using more. Sensory homunculus is which part of the body I'm receiving information more. And naturally, as you can see, the hands and mouth are probably the biggest. So because we use this extensively, and if you look at evolution, probably this also tells us that the two distinct features of human beings compared to animals is the hand as well as the mouth, or communication plays a major role in this, right? So we talk about mouth as well as hand as a very unique. Now, what does it talk about plasticity? Is that for some reason this person loses the one limb in an amputation, then the area which is representing that particular limb is going to shrink, and the area which is adjacent to it, or the area which is compensating for it. For example, if the left hand is amputated, the right hand is going to do both the work, and so the right hand is going to become bigger in size in the brain. So this is the internal map that we can see in the brain. So there are some mechanisms by which the plastic changes happen, both at the level of the structure and function, and at the level of as a gross at cortical level, as well as at the cellular level. While the focus is more of clinical applications for this particular discussion. I have just given you a brief overview about this. Probably we can share some literature around this on how these different mechanisms work and how they unique later on. So today we are going to focus more on the clinical application. And just to give you a bird's eye view of what we actually mean by these changes. So when you look at structural changes, the sprouting means that newer branches come out of the axons. Similarly, pruning means it's a withdrawal of a branch. So this cutting down of a branch is called pruning. So similarly, functional changes could be long-term potentiation and depression. Long-term potentiation essentially means that in making it something easy. As we practice certain things more again and again, like driving a car or a two-wheeler, it becomes easier for us to apply brakes when we need it and all of that. So those things kind of learning becomes called long-term potentiation. The same applies to depression when we do not use for certain practices or activities, then these are withdrawn. So these are functional changes, and functional changes also means that when one part of the body one part of the brain is not active or not because of stroke or injury, then the adjacent part takes over. So at the cortical level, the expansion happens as we discussed earlier, as well as substitution happens. One part replaces the other. At the cellular level, it's more of more dendritic spines being formed, and there's a neurogenesis that happens. So overall, the changes that happen in the brain are at multiple levels, and they enable the person to learn or unlearn a movement. So I found this interesting video, and this shows that how the neurons are actually trying to connect with each other.
What you're looking at here are two neurons under the microscope that I've filmed. And if you wait really patiently, you'll be able to see them connecting to one another.
So this changes happen over a period of time, and the timeline has been fast forwarded for us to get the quick response. But this change where a newer connection is formed and established, it may take from weeks to months.
What?
So that also brings us to some interesting case studies. One of this is primarily about the London taxi drivers. In London, as we know, the taxi driver, it's not easy to become a taxi driver because you have to pass an examination. And that examination, it's quite grueling for the taxi driver. They have to memorize the routes, and they have to understand almost 25,000 street names, plus the landmarks and a lot of other things. So let's have a look at the short video about the London taxi drivers.
Vying for attention with London's red buses, black cabs are most famous symbols of the British capital. With around 20,000 in circulation, they're well loved for their spacious and comfortable interiors. But what really sets them apart is their drivers. Without the aid of a GPS, they know the city's labyrinthine street pattern better than anyone.
A lot of the times you do it without thinking too much. There's not a lot of stress involved. You just think, OK, I've got to head this way, and away we go. And how can I get the people there, the passenger there, as quick as possible? Your brain gets conditioned to work this way.
Their impressive ability to orientate themselves in the city has spurred scientists to study London cab drivers' brains. Research shows that working as a black cab driver develops a particular part of the brain known as the hippocampus.
We'd seen how the hippocampus appeared to be linked to spatial memory, to learning, through the description of place cells.
The foundation of all this brain activity is known as the knowledge, the grueling training London's taxi drivers have to undergo before gaining their licence. Tests are carried out at schools like this one. The atmosphere resembles a university library. The students, mostly men, undergo 6 hours of intense training per day. The aim is to memorise the names and locations of 25,000 streets, where London's 8 million plus population live and work.
Yeah, so what we see here is that when the scientists actually looked at the scans of the brain of these London taxi drivers, they found that the hippocampus was actually enlarged compared to the normal population. So this is a another evidence that when people are actually using a part of the brain, it's not only a functional change, not at the level of just the neurotransmitters or the receptors, but actually the size itself also increases. So let's have a quick recap. So I would like to know what is your understanding of this? According to the sensory homunculus model, how does the brain recognize and allocate representation to different body parts? So we have 4 options here. You can give the options, the answers in the chat box. Is it based strictly on the actual anatomical size, or it's based on the distance of the body part? It's based on the total weight and muscle mass, or it's based on how frequently and actively the body part is being used? So let me give you a few seconds to respond to this. Which of these is the answer? You can just type A, B, C, or D. Thank you. Yeah, so let's look at the answer, and it is based on how frequently and actively the body part is being used. So let's move on. So there are different types of plasticity. There is a developmental plasticity, which happens as part of the normal growth and development of an individual. There's experience-dependent plasticity, which is where primarily we have a role to play, because as neuro rehab clinicians, we have a role in modifying the experience of the patient and giving them the right kind of experience, as well as maladaptive plasticity. So developmental plasticity essentially means that how the number of neurons grow and connect and form synapses and over a period of time. And as we know, at birth, we have lesser and lesser connections. And as the child has multiple experiences and a variety of exposures with their own body initially, and then with the environment, and then with the tasks, so the number of connections regularly increases. In fact, the number of neurons in a baby is actually much more, but the number of connections are much lesser. Okay, and around 5 to 6 years of age, there's something called as apoptosis, which is called as programmed cell death, and that happens again as part of a developmental process where unused and unwanted connections are then withdrawn and disconnected, so that there's less noise, there's less distraction, and the ones which the child had been using regularly, it becomes strengthened and reinforced. So this is part of normal development. So that brings us to the next topic, which is the experience-dependent neuroplasticity. So this is based on the landmark study by Kleem and Jones in 2008, and they identified 10 principles of experience-dependent neuroplasticity. I'm sure we're aware of some of these examples, like use it or lose it. So overall, they looked at 10 different principles, and let's look at what are these principles and how we can use it in our day-to-day practice. The first principle is the use it and lose it, and which means that the neural circuits which are not being used will naturally go for a degradation or weaning off. So continued movement and cognitive stimulation is important. Here, what we need to understand is just doing the movement alone is not enough. There has to be a cognitive demand on that individual as well. Okay, a very classical sign is constraint-induced movement therapy, where we know that if a person with hemiparesis, we restrict the use of the unaffected limb so that the person is forced to use the affected limb more. And this has shown to have a very positive impact on getting some of the neurons back to life, or activating dormant connections. So where if we don't use it, we will lose it. The second principle is that of use it and improve it. So that also explains that if I am not good at something, if I continue to practice that over a period of time, I'm going to improve that, and therefore which also means that the connections are getting established in the brain and they become stronger over a period of time. A very nice example of this would be a backward brains bicycle. So let me play this video for you.
No one would be able to ride this bike because it is the world's most challenging bicycle. Introducing the Brain Cycle. It may look like a regular bicycle, but its steering works in reverse. Turning the handle to the right makes the wheel move left, and turning it left makes the wheel go right. Mastering it is nearly impossible on the first try.
Yeah, so an interesting thing that came out is very a novel way of looking at how the it's more of it started as an engineering experiment and then it became more of a brain study. The person who actually invented this bicycle, he said that it took him 8 months to actually learn how to ride this. It was so challenging. And something even more interesting was that his 8-year-old son was able to learn this in 2 weeks. Okay, so that tells us about two things. One is that we can definitely see that the plasticity is higher in the younger age group, and therefore the learning is faster compared to an older adult. But similarly, we also need to understand that the elderly or the adult is already aware of how to ride a bicycle. For him to learn this backwards brain bicycle, he has to unlearn that first and then relearn it. So unlearning is also part of the entire process, and that's even more difficult than learning it. Whereas the child only has to learn the moment, and there's nothing to unlearn. So, but eventually the person was able to do it, which tells us that if when you use something regularly, we improve it. We also talk about this famous Bruce Lee's dialogue that if you do something 10,000 times, you become good at it. And I'm more scared of a person who practices one move 10,000 times than who practices 10,000 moves one time, right? So all these things talk about when you do consistently, you improve on your performances. And therefore, rehab programs must challenge the patient appropriately and take them step by step to the next level.
No one would.
The third principle is that of specificity. The nature of the training is very important. So it cannot be a random sit to stand or a walk exercises or reach exercises, right? It has to be much more specific. It has been found that when it is more specific, you have better learning and newer formation of dendritic spines as well. So the task that is being trained has to be much more specific. So this was the experiment which they had done with the Kleem and Jones had done with the single pellet reach task. So let me just quickly play this video to show you how it actually was designed.
Step is to allow mice to become familiar with the training chamber and food pellets.
So they put a mice inside a training chamber, and it has a head. As you can see, there are 3 slits on that, and they had put some food pellets, okay, which the mice can eat.
Next, food pellets are put within reach of the shaping slit and the preferred forelimb.
Yeah, so then they put it right in front of that, and the mice had to actually put the hand out, I mean the forelimb out, and pick up the pellet. Okay, and it's they also measured which limb was preferred for the mice.
Used for retrieval is determined. After the shaping period, the mice are trained with the single pellet reaching task, and the number of correct reaches with the preferred paw is recorded. Ultimately, this protocol provides a behavioral paradigm.
So then the mice was trained, and they looked at how which limb the mice was using, and because it's specific, when the slit was too small, right? So the mice cannot directly go and take the mouth or take it and eat it. So it has to pick up and it has to turn it and then bring it closer. So that demand on the mice when they studied the brain after that, they could see that the dendritic spines had increased in this mice compared to other mice which were placed inside a rolling drum, like something like a treadmill kind of thing, where there's not much to think about or learn about.
Step is
the next principle is that of repetition. So repetition, as we know, the more and more we repeat, we are able to get the best outcomes, and the practice is essentially comes through repetitions, and it strengthens the existing network. And one of the key application of this is there's a gentle tendency for us to give activities to the patients where we ask them to repeat, let's say 10 times, 20 to 30 times, or sometimes 90 times. And what is also important is to have variability in the repetition. So there is a statement that we usually is discussed here. It's called repetition without repetition. So that what does that mean is I am going to repeat the task, but at the same time, I'm not going to do it in the same way. So there has to be a variability of practice is very important. If I just give you an example, like how many times we bend our elbow in a day, right? So we bend so many times, we actually don't have a count on that, but we do it for a variety of purposes. The context includes brushing our teeth, washing our face, using mobile phones, eating, combing, and a lot more activities. So we bend our elbow for so many different reasons. So what is actually happening is we are getting that repetition without just doing the same thing again and again, but in a variety of context. So that is very important for motor learning. So how do we bring this in our day-to-day practice? Let's look at the simple math here. So overall, let's assume that a patient comes to you for 1 hour of therapy session for 6 days a week, assuming Sunday is a holiday. So we have 1 hour into 6 days. So totally it is 6 hours. And now when we give a home exercise program to the patient, and let's say the patient is doing it for 1 hour every day, and 6 out of 7 days is able to do it. So it's almost 6 hours per week of home exercise program. So overall, the total hours of therapy is 6 plus 6, total 12 hours. Now, I would say that based on my experience, this would be a very idealistic situation. Many times it's much below this number. But even in an idealistic situation, we can see that the total hours of therapy that the patient is receiving is only 12 hours per week out of 24 into 7, which is 168 hours. So out of 168 hours, the patient is receiving therapy only for 12 hours. So that makes it that the number of hours the patient is without practice is 156 hours. That's a very big number. And when we look at this, it shows us that the 93% of the time, the patient is actually doing something without the right kind of experience. And that would naturally have this bring us to this question: what will the brain learn, and what is the solution? Right? Because the patient, you have done your best, you have given the exercises, and I'm sure most of you will agree with me. You did the stretching, you did the exercises, the patient showed very good progress within the particular session. But when he comes back to the next session, he's back to square one. Right? You think that I'm doing the same thing again and again, the patient is not making much of a progress. Now, why is that so, and what is the solution? The issue is very clear that instead of the number of repetitions and opportunities that the patient is getting is very less. And what is the solution? The solution can be increase the number of exercises. You can just put that in the chat box as well. Do you say that if I increase the home exercise program from one session 1 hour to 3 hours, and then the therapy session from 1 hour to 2 times a day, so will that be a solution? So even that would make it 5 hours per day in a very extremely idealistic situation. I don't think it's more aspirational than practical. And even 5 hours per day into 6 days would make it only 30 hours, right? So the solution is not in adding more exercises or doing it more often. The solution is therapeutic routines. So what do I mean by therapeutic routine? As the patient is going to do certain activities on a daily routine, naturally, right? He's going to eat, he's going to stand up or walk or go to restroom, and he's going to take bath. So can we make these routines therapeutic? So when I say therapeutic, what is the position of the person when he's sitting and watching television? What is the position of the affected hemiparetic limb when he's actually eating food with unaffected hand? Okay, is it just relaxing on the thigh, or is it holding the table or holding the plate? So it could also mean like when I'm brushing my teeth, what is the affected limb doing? Is it placed on the sink or on the wall on the sink and near the sink, or is it just I'm holding it closer to my body? So all of this has to be considered, and we have to ensure that each and every aspect of it. What is the position of the patient when he's sleeping? Okay, we are focusing on standing and walking as a goal. So maybe if possible, I would go for something like a prone lying if it's possible for a patient to get that hip extension when he's sleeping. Okay, if the patient is obese, can I go for a quarter prone lying with with one limb which is completely into extension, the other limb can be on a slightly flexed position, and we get some nice dissociation between the lower limbs. So all of this should be considered when you are providing a home exercise program, because we're not just limiting that to exercises, we're also looking at the routines. And the best part of doing something with routines is that the practice or the repetition becomes natural, because every day the person is going to do the same thing over and over again. So that's going to build up on the hours of practice. And that's going to have a cumulative effect on the outcome. So the next principle is that of intensity. The intensity must be sufficiently challenging to drive significant change. So what does it mean is that the exercises that we give to the patient should be challenging enough. And low intensity therapy, like, is more like, if somebody says that he's a very good therapist, he makes me very comfortable and he doesn't push me much, then I'm sure like you're not doing the right thing. You have to push the patient. And it's important for us to know how much we have to push the patient, right? So let's look at giving the right challenge to the patient without the added stress of doing exercises. We want the patient to think out of the box or give that extra yard of effort, but not get frustrated with the exercises. So if you look at this, this is a very standard thing. We all of us know that when there is a stress, some amount of stress is good, because you think it makes you, it's a driving force for you to do well. But when the stress increases, then the performance declines, right? The quality of performance, as you can see, you can see that in the upward trend. And when it reaches a peak and when the stress continues beyond that, there's an overload, there's fatigue and exhaustion. So if I look at this from a therapy point of view, we have to definitely challenge the patient, because if you don't challenge, the patient is not going to go from one level to the next level. So the challenge is where you see that the first half of it. So some amount of challenge, some amount of stress is good for the patient and has to be the right challenge. But when it continues, it becomes frustration and can have negative consequences. The next principle talks about time, like when do you start the therapy and exercises, and timing of intervention is very important. We all know that early intervention is very important for cerebral palsy as well. But it's not just only for children. Early intervention means that how sooner do I start the intervention after the brain is injured or damaged, right? It could be post-stroke, like how sooner can I start the intervention once the patient is medically stable. And we all know that the maximum gains are measured only when the patient is in subacute stage. In chronic stage, we get those gains, but it's a lot more slower. So given a choice, if it is possible, then always focus on early intervention and try to maximize the period of subacute stage, which is usually 14 days to 3 months post-stroke. The next principle talks about salience. Salience means that how meaningful is it for the patient. So when you are giving a task like sit to stand, so what should he do when he does sit to stand? So sitting to standing, and in standing, does he reach for something overhead? Okay, so which he cannot reach in sitting. So there becomes a task associated with that. Similarly, when you're asking him to reach something, so give him an object which he's able to relate to. Asking a person to reach forward and touch a ball or a wall may not be so exciting or interesting for the patient or meaningful for the patient. But if you ask him to reach out and touch a water bottle or a cup of coffee, even if it's an empty cup, that would be much more meaningful. In fact, I remember when I was working with one patient and I gave him a pen. I just kept it out of his reach. He used to write every day so I asked him to just pick up the pen. So after he touched the pen, he said, "I'm touching this pen for after 6 months," right? So that makes him a lot more meaningful for the subject or the patient. And now what do we understand from this, or how do I use it, is first of all, use objects and interactions which are relatable for the patient. And number two is jointly decide on the goal with the patient, because the patient should know what are we working on. Too many times when I discuss with therapists, what is your goal for this patient? They say, I want to improve balance, I want to improve range of motion, I want to improve the muscle power. See, when you say that you are going to improve this is only an aim or an objective, and this is only telling me that you have nice intentions, you're a good person. but does it really translate into outcomes? Because if I have a goal of improving balance, I can work for the next 10 years with this patient to improve balance, because I can still improve, right? I can improve my own balance as well. Standing on one foot or hopping on one foot for 100 steps can be my goal, right? So the improving balance or improving some particular activity it's never ending. So, but when we have a SMART goal, so what is a SMART? Specific, measurable, achievable, relatable, or rational goal, and time bound. So when we have a time bound goal, so I want the person to be able to stand holding a walker for 30 seconds. Okay. So now this is very much specific. When we have a goal like this, it tells us clearly that have we achieved this goal or not, right? After 3 months, when you look back at this document, you'll know by 3 months time, my goal was to make him stand holding a walker for 30 seconds, and he has achieved it or not. So this is only yes or no. It's a binary response. So that makes it much more clear. And when you show this goal to the patient, that in 3 months' time we are working towards this. So if you are well aligned with this, we should be able to achieve this. Now the patient understands, yeah, I want to stand up, I want to walk, I want to go to the restroom independently. And then the patient tells you, like, tell me what should I do at home, right? So that tells you that the patient is no longer just a passive recipient. He is a part of the rehab team. Too many times we talk about rehab team being a part of physios, occupational therapists, and other people. But what is actually a rehab team without a patient, right? The patient is at the center of it. So if we consider them as a partner to this team, I'm sure the outcomes are going to be much more better. And there's a buy-in from the patient as well. The age matters, which means that we already discussed about the backward brain bicycle. The younger the patient, then the better the prognosis. So it also tells us that we can have more aggressive goals and we can push the limits with the younger patients as well. A transference is another principle, which means that when we learn a particular skill, we are not just working on that particular skill, we are also using this to learn some other skill. Okay, for example, if I learn how to play a keyboard, a music instrument, or I learn how to type on a laptop, right? So that skill is going to do 30% of my work, just to give an arbitrary number. It gives 30% of my work is done when I go for the piano. I'm sure, like, all of you who know typing and you're very familiar with the QWERTY keyboard, you find it very easy when it's QWERTY rather than when it is ABCD, when you're using your remote in YouTube and trying to key in the movie name, right? So when you actually do one skill, it becomes easier when you do something similar. So that skill transfer is again a part of neuroplasticity, because the same set of neurons get activated. And it also depends on how the patient is able to perceive the similarity between the tasks. Okay, so that is also going to determine that. And the last principle is that of interference. So what is interference? Just like transference, it's the opposite of transference. For example, transference is something which is going to help you to learn a new skill by giving you a head start. Whereas interference is the opposite. If I choose two goals, which are actually contradictory to each other, then when I work on one goal, I'm actually doing the injustice to the other goal. I cannot work on both these goals at the same time. So that is the interference. So the interference here, it means that we have to be very careful and choosy in deciding what activities to be done, what should be the sequence of these activities, and what are the goals. When you're parallelly working on two goals, these goals should not be conflicting each other. Many times we see therapists initially who follow a developmental milestone pattern for cerebral palsy. They go for a goal of crawling, and once the crawling, let's say it's achieved, they now are going for standing and walking. Now this crawling and standing, they actually are conflicting, because crawling is a lot more flexor dominant activity, whereas standing and walking is more extension dominant. So if you want the child to eventually achieve standing and walking, why are we working on crawling? That's going to delay standing and walking further. Now, assuming we are talking about a child who's 4 years or 5-year-old, then crawling also doesn't make sense when it is not age appropriate as well, right? So one goal should not lead or be conflicting with another goal. I also saw one patient who had focal dystonia. It's more like he was not able to hold his pen and write, so he was given botulinum toxin injections on the finger extensors, and so that he can hold the object. And he said he wanted to write, and so I said, yeah, we can definitely help you with that. And then he said, like, I'm also working on the in the IT, and I need to also do typing, and I'm not able to do typing. So I said, like, I can either choose writing as a goal or typing as a goal, because writing is a lot more flexor dominant activity, typing is a lot more extensor dominant activity. I want finger extension more for typing, right? So I can either work on this or I can work on that. I cannot work on both at the same time. If my first goal is achieved, then probably I can look at typing at a later stage. So you tell me, what is your priority? You want to write or you want to type, right? So that is how we have to be clear with what is the the movement that we are targeting, which muscles have to be worked, and how and we need to avoid goals that could be conflicting each other, because at the end of the day, the person may not achieve both writing as well as typing in this example. To summarize it, we have the 10 principles, and I was looking at how I can make it easy for us to remember those 10 key principles of experience-dependent neuroplasticity. So I got to this, which is IIT Lassi is right for you. So this way we can remember all these things, and remember that these 10 points are not mutually exclusive. While we are trying to understand it and put it more like in a summary, but in essence, when you're working with a patient, you're naturally doing use it and lose it principle will naturally work along with use it and improve it, right? Similarly, you have, when you give a task which is specific, right? So you're using it, use it or lose it, plus specificity, plus repetition, and plus transfer, they all go together, right? So they're not mutually exclusive. So the understanding that these are different ways in which plasticity helps is to understand how the brain works, and there are different aspects of which needs to be considered when you're giving any exercise or activity. So that brings us to the reinforcement corner. I hope you were able to follow this discussion. So please give me an answer for this question, and you can put it in the chat box. Which principle of experience-dependent neuroplasticity emphasizes that the specific nature of training task dictates the specific changes in the cortical mapping? So we have 4 options: repetition, salience, specificity, and transference. Out of these 4, which do you think is targeting the specific nature of the training task? Let me give you a few seconds to respond to this in the chat box. Yeah, and the answer is specificity. So there are some factors which influence plasticity, which we also need to be aware of, such as the aerobic exercises, the sleep quality, how attentive the patient is and participating in that exercises, and when you're having some interesting or novelty in whatever you do. And similarly, stress or chronic stress is going to be an inhibitor. Similarly, if the patient is isolated, or you're doing something as a routine, doing the same exercise, to stand 10 times, 30 times, 100 times, whatever is your belief system. When you do the same thing without much variety, that's also going to dampen the spirits, and the person gets cut off from the therapy as such. And they're not. Whenever we do any movement, there's always a component of problem solving attached to it, right? So it's important that we need to have that variety, and we need to engage the patient actively during these training sessions. So with this, we come to the end of part 1. A quick sneak peek into part 2. What are we going to discuss in the next section? We're going to discuss about maladaptive plasticity and how active learning is compared to passive learning, and a few tips on motor learning principle, which relates to plasticity, and common mistakes done by novice PTs, which we can avoid in the best interests of the patient as well. Right. So we shall be discussing about these topics in the part 2. So thank you very much for your patient listening.
Thank you very much, Dr. Karthik, for this insightful session. I hope the listeners would have gained from your experience and practical perspectives, and also the evidence-based methods and practical principles that you have enlightened us with. I would also like that the participants, I would like to thank all the participants for their enthusiastic presence, answering questions and asking questions, and their active engagement. And I would request them to join for part 2 with the same enthusiasm. Thank you so much.
Thank you.